technicians, can they play back the pre-recorded presentation?
Good afternoon, ladies and gentlemen. I'm happy to join the Central Vietnamese Heart Association Congress, and I will present you some challenging cases in the context of acute myocardial infarction and acute coronary syndrome in the hospital of Wolfsburg, Germany. So my first case is a 56-year-old man. He's working in the Volkswagen factory, which is just 15 minutes from our hospital. And he's a current smoker and has chest pain since some days. But this morning, when he arrived at work at 6:50, he had very severe chest pain. And he went to the emergency department of the factory, and they did an ECG immediately. As you can see, the emergency call was about 2 minutes before 7 here, and the ECG was done 15 minutes later, which is quite good. And this is what the ECG showed. You see a large myocardial inferior infarction, and the colleagues of the emergency department in the factory, they called us in the hospital. They gave us a phone call to tell us here is a man, 56 years old, with a large infarction. And so we could prepare in the cath lab for this patient to arrive. And when he arrived in the cath lab, we found the right coronary artery occluded, as you see here in the proximal part. It's a quite big artery, and left is non-severely diseased. And we put a wire through, and then we found a large thrombus here. So you see the white material here. So we decided to proceed for thrombus aspiration, which we did here, and we got some red clot out of this artery. And as you know, it's not a standard in the guidelines to do thrombus aspiration. It's even guidelines say routine use is not recommended, but it says routine. In selected cases, there's even an advantage in mortality. So in cases of large residual thrombus burden, you can do that. And this is what we had when we placed the stent, and we were very content with this result. And we had only a small inferior hypokinesia in this patient, which had been treated, as you can see, about 1 hour and 20 minutes after onset of symptoms. So to achieve 1 hour and 20 minutes, you have to do not only a good procedure, but you have to do good logistics. So we had the phone call from the factory emergency department to our emergency department, and we had the patient directly transferred to the cath lab, from the ambulance car to the cath lab. No stop at the emergency department, no stop at the intensive care unit. And this is crucial. So if we can achieve only 1 hour and a little bit from onset of symptoms, we can preserve the left ventricular function most optimally. My second case shows a 69-year-old man, and he had chest pain in the night, maybe 4 o'clock in the early morning, but he did not call the ambulance. So he went to his family doctor, and when he arrived there, it was 10, and when the ECG was done, it was almost 11, and the ECG showed inferior myocardial infarction also, and this patient was brought by ambulance to our cath lab, and we found tachycardia, right bundle branch block, and in bundle branch block it's sometimes difficult to recognize ST segment elevation, but here you can see in 2, 3, and VF we have large inferior infarction, and the symptoms are about 6 hours old now. And this patient is in beginning cardiogenic shock. As you can see, the arterial pressure is low and he's tachycardic. And what we find is right coronary artery not severely diseased, surprisingly, because the ECG suggested right coronary problem. And then we found left circumflex occluded here. But as I told you, some hours already is occluded, and we find additional high-grade stenosis in the LAD directly after the left main. So what should we do? Should we do the LAD or should we do the circumflex artery? We decided to wire both vessels, which was moderately difficult. And after wiring, we have flow here in the circumflex artery. And then we put a stent here. And we were quite confident with the result. And we had here some side branch problem, which we didn't address. And then we had to decide whether we should do or not the high proximal LAD. And we decided to do that. And we put a stent just adjacent to the left main and inflated the stent. And we got a quite good result, as you can see here. So we did non-infarct-related artery in the context of acute coronary syndrome with cardiogenic shock. You see we have good results here in different projections, and we have a rather severely depressed left ventricular function, not only in the inferior part, as you see here, and in the lateral wall, as you see here, but also in the anterior wall. So I think we were right to do the left anterior descendant artery with the infarct-related artery, especially because the hemodynamic situation was bad. So this patient had a large CK rise, and he had persistent left ventricular impairment after 5 days due to the fact he arrived only 6 hours after the onset of symptoms. So guidelines say maybe we should consider this, but we should not do it routinely, as it's stated here, but we have to choose, as in the thrombus aspiration, selected cases where it can be done with little risk and good procedural result. So next patient, he was 76 years old, and he came to our hospital with chest pain since several days. He has chronic coronary disease with a stent in the right coronary artery 20 years ago, and he had end-STEMI, troponin elevated, and ST segment depression, not ST segment elevation. And surprisingly, left ventricular function is quite good, and right coronary artery with the old stent also is good. So we have the impression this patient has no severe coronary stenosis. But we have to look closely, and we find high-grade left circumflex osteal lesion. So we did, and if you look closer, we find left main is also not safe. So we have to do bifurcation intervention in this case, and we wire both vessels, and we did pre-dilatation to the circumflex, and then we did a stent implantation with a balloon in the left LAD and the stent in the circumflex with simultaneous balloon inflation, and we got a rather good result. In this case, we preserved left main, we preserved LAD, and we got the circumflex open. So this is a quite challenging case, which I show you here, and we got a good result. And in another patient, 60 years old, we have severe ischemia with ST segment elevation in VR and ST segment, here you see VR and ST segment depression in nearly every other lead, which has chest left main disease or three vessel disease. And this patient has cardiogenic shock also, and his angiogram shows right coronary artery stenosis and collaterals to the left, as you can see here. And this patient has severe left main disease with a large burden of atherosclerotic material. So in this case, we decided not, he has another lesion here in the circumflex also, so we decided not to go for intervention. Left ventricular function is preserved, a lot of calcification here in the area of left main, and we decided to send him to Cabbage, where he was operated in the same afternoon, about 3 hours later, with a very good result. So we must know we cannot do every patient in the cath lab. We should be prudent and courageous at the same time, and so we can get results for our patients. Thank you for your attention.
Okay, thank you, Dr. Fleischmann. Unfortunately,